Hi everyone, this is John Mandrola from the Heart.org Medscape Cardiology, and I'm here at the American College of Cardiology meeting in New Orleans, and I'm pleased to welcome Dr. Raj Makkar, who is the Associate Clinical Director of the Cedars-Sinai Heart Institute. Welcome, Raj.
Pleasure to be here, John.
This was a huge day for cardiology with the transcatheter aortic valve trials in low-risk patients. I mean, what were your general impressions?
I agreed with Dr. Eugene Braunwald when he commented that this was a historical day, because I think today we essentially changed the treatment of aortic stenosis in low-risk patients. So as you know, the transcatheter aortic valve indications have expanded now. It was approved for high-risk patients and intermediate-risk patients, and today, which is where majority of patients are, young, low-risk patients for surgery, they in fact will now be preferentially treated by using transcatheter techniques. So two low-risk studies, as you know, were presented today. The first one was with the SAPIEN 3 valve, and essentially that trial showed that the combined endpoint of death, stroke, and rehospitalization was cut in half, with the use of transcatheter aortic valve compared to the traditional conventional surgical aortic valve replacement. So not only did we see some reduction in mortality, but a significant reduction in stroke rates. And yes, a lot of this was driven by rehospitalizations, but nonetheless, there was beneficial trend in all of these endpoints that were actually measured.
And the Evolut trial?
And of course, the Evolut trial. So I think it was essentially the same thing. You had this trial that enrolled 1,400 patients. This is done using a little bit of a different trial design called the Bayesian trial design. And essentially, once again, in terms of the endpoints of death and stroke, it was non-inferior compared to surgery. So I think you essentially saw similar outcomes here. The stroke rates were also lower in this trial as well with transcatheter aortic valve than they were with surgical aortic valve replacement.
Yeah, so can you speak to the whole evidence generation of the transcatheter from beginning to end? I mean, I kind of think it's pretty remarkable and reminds me of the cardiology of old.
Yes, I mean, I think it's amazing. From the first time that Alan Crebier actually did this in somebody who was not a candidate for surgery, this is, more than 15 years ago, as a last-ditch thing, where it was thought that we will actually use this technology as a niche only in a small subset of patients who are absolutely not candidates for surgery, to this 15-year journey later on, where this has actually replaced what was the gold standard. The surgical aortic valve replacement is indeed quite an amazing thing. And I think it's amazing because of the way also it was done and the way the field was led by some of the leaders, by systematically accumulating evidence, starting from inoperable patients to high-risk patients to intermediate-risk patients, right, and now finally the final step, which is the low-risk patients.
Can I ask you some specifics about it? What do you think? For me, I worry about valve durability, right? So we're going to be doing this in lower-risk patients who are younger. And so if you do a patient who's 88 or 90 years old, maybe durability is not such a big issue. But can you speak to that?
So, John, I think you have a very important point, durability, right? So the question is, are we trading some of these endpoints for long-term durability? It's good to be alive, good to have a lower incidence of stroke rates, but I think durability is important. What we know is the following. We know that not in large data sets, but in small data sets, up to 5 years, the durability seems to be comparable to the surgical aortic valve replacement. What we also know is that the traditional definitions of durability with surgical aortic valve replacement are quite flawed, in fact. All right. So if just freedom from reoperation doesn't mean that the valve is durable. A patient who had a surgical aortic valve replacement could be dying from valve degeneration. If it doesn't come back for a reoperation or TAVR, it was considered to be freedom from reoperation, right? Yeah. That's the way it was traditionally defined. Now, moving forward, we have uniform definitions of durability for surgical aortic valves and transcatheter aortic valves. And I think now we will actually get the right answer. Now imagine if the notion that surgical valves last for a very long time was always true, why would 20% of the patients who are getting valve-in-valve procedures, okay, that is valve in degenerated surgical bioprosthetic valves. So in the VIVID registry, 20% of these patients had their surgical aortic valves replaced within the 5 years prior to the TAVR, all right? So it's a bell-shaped curve, but there are patients who will degenerate earlier, and that is true also for the surgical aortic valve. So I think the data is not that good in terms of its rigor when we talk about the surgical aortic valves.
Right. Before we talk about the bicuspids, I want to ask you about another specific, and that is in the Evolute trial, the business about a much higher rate of pacemakers. I mean, to me, as a pacemaker implanter, I think we should try not to put in pacemakers. I mean, can you comment about that?
Yes. So the pacemaker rates were higher in the Evolute trial, you're right, compared to surgery, and I think that was the only big limitation, because everywhere else, including hemodynamics, everything else was actually really good. I think some of this can be mitigated by technique, all right? So I think it is not uncommon for some high volume centers to have pacemaker rates that are much lower, around 10%. Now, it is true that balloon expandable valve, they actually have much lower pacemaker rates. So in the SAPIEN in the other study, the SAPIEN 3 study, basically the pacemaker rates were not very different, 6% versus 4%, all right? So I think that some of this will probably come down with learning. Also, as has been pointed out several times, that half of the times when you look at these patients, they're actually not using their pacemakers at follow-up. So how do we better risk stratify? I think there is some work that actually needs to be done in that field.
Okay. Now, there were 0 patients with bicuspid aortic valve disease in these trials, but there are a lot of patients with bicuspid aortic valve disease, and you presented a paper today on that. Can you tell us about that?
Yes, John. So, according to some studies, almost half of the patients that are young and are undergoing surgical aortic valve replacement, the reason up to half could be actually bicuspid aortic valve. And since all the pivotal studies excluded these patients, there's paucity of data. So what we did was we went to the STS ACC TVT registry, which enrolls all consecutive patients getting TAVR in the United States. It's an amazing repository of data. And there were 92,000 patients with the SAPIEN 3 valve in the 3-year period that we actually studied. And there were 2,700 bicuspid valves. What we did was we took these patients and we compared them and their outcomes to the outcomes of the tricuspid aortic stenosis patients, and we propensity matched them so that they are equivalent in terms of their cohort. And what we found was that at 30 days and at 1 year, the survival was similar. We also found that there was somewhat higher risk of aortic root injury with the bicuspid TAVR, but nonetheless, that was still less than 1%. So it is more than tricuspid, statistically significant, but less than 1%, something that can be justifiable. What we also found was that the stroke rates were higher, though. They were somewhat higher, 2.4% versus 1.6%.
This is TAVR versus the
that's TAVR versus tricuspid. So it's TAVR in bicuspid versus TAVR in tricuspid.
Okay.
All right. Now, most of these were done without the use of the cerebral protection devices. So I'm sure we can make a difference there when we're doing these TAVR cases. We can actually use embolic protection devices. And the hemodynamics were similar, and the quality of life indices were similar. So I think what we did was we bust the myth where some people believe that bicuspid aortic valves can't be treated with TAVR. You can, and you can get good results. But it's also important to point out that all bicuspid aortic valves are not the same.
Yeah.
Some are more hostile anatomies, and preferentially we must avoid those so that we actually get reasonable outcomes. And I would say that it's easy to justify the use of TAVR in high risk and intermediate risk patients. Because there's no data in low risk patients, the right thing to do would be to do a randomized clinical trial.
So that's what this data, which this propensity matching would be kind of hypothesis generating, that that's the patients we should do the trial in.
Yes, I would say in the low risk patients. I mean, the data that we have is in the high risk and intermediate risk because these are the patients being treated. And, 2,700 patients is a good number of patients and it gives us reasonable confidence that you can treat these patients with TAVR. But you have to also realize that there was a selection bias in the way the patients were treated, right? So if I was treating some of these patients when I had very hostile anatomies, I didn't treat them. So this does not give us a blanket approval to treat every bicuspid. We must carefully look at the anatomy on CT and then decide what to treat and what not to treat.
Excellent. Excellent. Thank you so much for being with us.
Pleasure, John.